On my first day of medical school, I knew two things. The first thing was that I wanted to be a doctor. And the second thing was that the way that I was going to help people was through personal connection and one-on-one intervention. I didn't know exactly what type of doctor I wanted to be, though, until I was walking down a hospital hallway and I made eye contact with a woman who was recently postpartum. She was being rolled down the hallway in a wheelchair to see her newborn in the NICU. And in that moment, we recognized each other, and I realized I had been present for her baby's birth. And this was a form of connection that felt special and deep and different from anything else I'd experienced in medicine. And so on my first day of training as an OB-GYN doctor, I set out to make a difference for people through personal connection and one-on-one intervention. Unfortunately, my sense of individual contribution began to unravel as I realized just how many conditions in pregnancy have more questions than answers. I participated in so many births that could have gone better, and I witnessed so much loss. And many, many times, the only answer I could find was that we do not know how to prevent these things from happening. And so as I was looking for a way to find meaning and purpose amid this impossible circumstance, I found research as a way of contributing to fill knowledge gaps and find answers so that things that feel unpreventable today can be simple matters of prevention in the future. My name is Nathan Blue, and I'm a specialist in high-risk pregnancy, which we also call maternal fetal medicine. And I know two things. First, my goal is to prevent stillbirth and to reduce infant mortality. And second, the way that we are going to do this, rather than through personal connection and one-on-one intervention, is through research. Today, I want to discuss stillbirth, fetal growth, and what I think is the holy grail of obstetric decision-making. Before we keep going, I just want to say, when we talk about stillbirth and pregnancy, things get personal really fast. So if anyone here is pregnant, or planning to be pregnant, or someone close to you is pregnant, and this is distressing, please come find me afterwards. So stillbirth may not seem common, but it is. 1 in every 175 babies is born still. That's over 0.5% of all births. This is what we are facing. I came to the University of Utah because we are nationally recognized in obstetrics research, particularly stillbirth. We recently launched a Center of Excellence in Stillbirth, the first of its kind in the US, and that was thanks to the leadership of Bob Silver, our department chair. And so this is what we are working on as a group together. This is what the risk of stillbirth looks like over the second half of pregnancy. On the bottom are the weeks of pregnancy, and on the left is the risk of stillbirth for every 1,000 births. And you can see on the left-hand side, that's the midpoint in pregnancy at 20 weeks. And at 20 weeks, there's a peak in stillbirth risk where fetal conditions that are incompatible with ongoing development have their influence and babies die. And then there's a low point at around 30 to 32 weeks before the risk begins increasing, and it does so for the rest of pregnancy. I have a friend named Dr. Jess Page, and she did foundational work in this area to quantify the percentage of these stillbirths that are potentially preventable. And what she found is that earlier, close to the low point, about 24% are potentially preventable. But as you get further along, it's closer to 40%. Now, this is poignant for us because term is 37 weeks, and that is when the risk of newborn complications from prematurity drops considerably. We begin asking ourselves, should we consider delivery? Is the risk of stillbirth high? For most people, the answer is no. We should wait until 39 weeks because that is when the risk is lowest for mother and newborn. But all of this underlies an uncomfortable truth in obstetrics, and that is that we have only one intervention to prevent stillbirth, and that's delivery. So the holy grail of obstetric decision-making is not what to do, but when. In order to know when to act, we need to know who is at risk. Now we come to my work. So we can't talk about stillbirth without talking about fetal growth restriction. Fetal growth restriction is when babies don't grow as well as they're supposed to. And in practice, we define this as fetal size in the bottom 10% for gestational age. We care about fetal growth restriction because it is a leading risk factor for stillbirth and because we can recognize it prenatally with ultrasound, which gives us an opportunity to act. But we have a problem. We did an analysis of just over 10,000 first-time pregnant participants, and in that group, these were the ones whose babies were normally grown. These were the ones diagnosed with fetal growth restriction by ultrasound, and these were the ones whose babies experienced some form of newborn complication, including stillbirth. And what I hope is clear to you is that most babies who experience complications appear to be normally grown, and most diagnosed with growth restriction were healthy at birth and didn't experience any complications whatsoever. And so this makes for a disconcerting reality in our clinic where I may have to tell someone, I'm sorry, it seems like your baby is not growing as well as we expect. It might be that your baby's perfectly fine, and actually there's no increased risk. You could bypass all of this intensive monitoring and potentially early delivery. Or it may be that your baby is actually quite at an elevated risk, and we need to monitor quite closely in order to prevent stillbirth so we know when to act. But I don't know which scenario we're in. See, we know fetal growth restriction, or FGR, leads to complications like stillbirth, but we don't always know when that's the case. And so when we try to do analyses that are more advanced to integrate other factors to help us understand this risk, we typically depend on a type of analysis called regression. And regression, what it does is it tries to isolate each risk factor's independent association with the outcome, which is helpful for knowing what factors are relevant, but it doesn't work in practice where a person in front of me is not just a list of risk factors that I can add up. In real life, we suspect that these risk factors have complex relationships with each other. So the risk that's added by fetal growth restriction is different for one person than it is for a different person with an entirely different set of circumstances. Probabilistic graphical models are an AI-based method that is able to capture these complex relationships, and this is what we are using to better understand and estimate risk. We spent the better part of 2 years deriving a probabilistic graphical model, and this is what we arrived at. So here is the morbidity or the newborn complications we're trying to predict, including stillbirth. These circles represent the risk factors that inform risk, and the lines represent the relationships between the variables, which we call conditional dependencies. And that's when two variables appear to be independent from each other, but actually, when in the presence of other variables, their relationship to the outcome changes. And so there's a lot of variables here, but I'll just show a few, and this includes things like fetal growth, maternal medication use, congenital malformations, maternal blood pressure, fetal sex, maternal diabetes. So using a model might look something like this. In the background of our population, the risk of any form of newborn complication or stillbirth is about 8%. And if we use this probabilistic graphical model to estimate the risk when we tell it we suspect fetal growth restriction, but we tell it nothing else, well, the estimate of risk is considerably higher, but still just a minority. We know so much more than this, though. And so if we tell the model everything we know, and perhaps that all factors are actually favorable, well, then our risk is actually very low, maybe even lower than where we started. In contrast, when some specific combinations of factors are unfavorable, the model can detect those synergies and identify scenarios where the risk is considerably higher, and this could be hugely impactful for my patients. Our model has promise, but we're not ready to use it because it's not ready. So we are carrying this work forward by integrating data from maternal and fetal genetics, as well as placental function, and factors in the environment that we expect or suspect influence risk. And in recognition of the promise of this work, the NIH has awarded us with 2 awards in the last 3 years. Neither of these would have been possible without initial investment from seed funding programs within the University of Utah. I want to thank my mentors and friends who make this work possible, and I want to circle back to the way that I want this conversation to go in the future. What I want is to be able to tell someone, your baby is small, but that's okay. I'm confident your baby is well. You can skip all of the stress and cost and monitoring and unnecessary intervention and carry on with a low-risk pregnancy. Or if your baby is truly at high risk, then I know with confidence that all of the monitoring is necessary, and we will know when to act in order to get you the healthiest birth possible. I still think about the woman who recognized me, the new mother in the hallway 17 years ago. And I wish things had been different for her family and for her baby. Now, so many years later, I know 2 things. The first is that every pregnant mother and parent deserves this moment with their newborn. The second is that we will get there, first through research, then through personal connection and one-on-one intervention. Thank you.